Hope, it is the pillar that holds up the world, says Pliny the Elder. Pillars are the structures that holds up the building. Similarly, local anesthesia is considered as the pillar that holds up the surgical and other invasive procedures. Hi, I am Dr. Akilan from the Department of Oral and Maxillofacial Surgery, here to present on the topic mandibular local anesthesia techniques. Today we will be discussing about a small gist about the anatomy of mandible, mandibular nerve and the various mandibular anesthesia techniques. So let's go into this presentation. As we know, the trigeminal nerve is the fifth cranial nerve which has three different branches: ophthalmic branch, maxillary nerve and mandibular division. The mandibular nerve is the third branch of the trigeminal nerve. It divides mainly into two branches after coming out through the cranium through foramen ovale. As we can see, so this is the middle cranial fossa inside, through which the mandibular nerve comes out through the foramen ovale. Once it comes out through the foramen ovale, it divides into anterior division and posterior division. Also, there is two different branches from the undivided portion. Those are nervus spinosus, nerve to the medial pterygoid muscle. From the anterior division arises the branches to various masticatory muscles like nerve to lateral pterygoid, nerve to masseter, nerve to temporalis and buccal nerve. The posterior division has 6 different branches like your auriculotemporal nerve, inferior alveolar nerve, lingual nerve, mylohyoid nerve, mental nerve and incisive nerve. So as we can see, here is the inferior alveolar nerve branch which enters the mandibular foramen, and here is the lingual nerve branch and mylohyoid nerve branch. So it innervates, it is a mixed branch which has both sensory and motor innervation. The sensory innervation includes the skin over the temple, over your cheek, lower lip and chin. So depositing local anesthetic solution within 1 millimeter in the range of the target nerve achieves the mandibular block. The problem with the mandibular blocks is it has significantly higher failure rate owing to its thicker cortical plate and various anatomical variation possibilities of the location of mandibular foramen. Let's see about inferior alveolar nerve block. Before going discussing about inferior alveolar nerve block, I would like to discuss few things about our mandibular bone and the parts of syringes. So this is our human mandible, and various parts including are, this is our condylar process, this is the coronoid process, and the depression in between is the sigmoid notch. This is the symphysis of our mandible, this is the angle of mandible, and this is the body portion of the mandible. Coming to various foramens, the foramen located in the medial aspect of the ramus is our mandibular foramen, and there is a tongue-like projection above the mandibular foramen known as lingula. And in the outer part of the mandibular body, we have a foramen called mental foramen, through which the mental branch of the mandibular nerve emerges out. And this is the ascending ramus, the portion beneath our coronoid process, and this, the deepest concavity in the ascending ramal region, is known as coronoid notch. So not to confuse, this is known as sigmoid notch or mandibular notch, whereas this is the coronoid notch, which is an important landmark for our inferior alveolar nerve block, which you are about to learn. Coming to parts of a syringe, so what I am holding in my hand is a single use disposable hypodermic syringe with needle. So this is the syringe, this cylindrical portion is called syringe barrel, and this is the piston, and this is our needle. What I am holding here is a short needle. In this plastic portion is known as the syringe adapter. The portion with the whitish area is known as hub. This is the needle shaft. and the sharp tip is known as the needle tip. The sharp pointy thing is the needle tip. And if we can closely observe, there is a angulated cut in the needle which is known as the bevel. So, bevel is an important part of the needle which has to be oriented in such a way for different techniques for us to achieve the effective anesthesia. So, coming to inferior alveolar nerve block, it is mostly referred to as mandibular nerve block. It is the second most frequently used after our supraperiosteal injection or infiltration technique. It has the highest percentage of clinical failures even when properly administered. The supplemental blocks for the inferior alveolar nerve blocks including long buccal nerve block to achieve anesthesia in the buccal aspect of mandibular molars, supraperiosteal injections which overlap the contralateral nerve mostly in the anterior region, periodontal ligament injection which gives isolated portion of mandibular teeth sensitive even after successful IANB, and intraosseous anesthesia which is required when there is ineffective IANB, primarily when the tooth is pulpally involved. So, here we can see the inferior alveolar nerve as it enters the mandibular foramen, and the buccal nerve which runs along the buccal aspect of the mandibular arch near the external oblique ridge. The mental nerve emerging through the mental foramen. The bilateral IANBs is rarely indicated other than bilateral mandibular surgeries because it gives considerable discomfort. Patient might feel difficulty in swallowing and they are likely to self-injure the anesthetized soft tissue. Nerves anesthetized in this technique includes the main nerve, that is your inferior alveolar nerve, incisive nerve, mental nerve and lingual nerve. Areas anesthetized are the mandibular teeth till the midline in the quadrant which we are anesthetizing, body of the mandible, inferior portion of the ramus, buccal mucoperiosteum and mucous membrane anterior to the mental foramen, anterior 2/3 of the tongue and floor of the oral cavity which is applied by the lingual nerve, and the lingual soft tissues and periosteum supplied by our lingual nerve. So, in this diagram we can see the areas shaded in yellow color are the areas anesthetized after achieving our proper inferior alveolar nerve block. The indication for inferior alveolar nerve block includes procedures on multiple mandibular teeth in one quadrant when buccal soft tissue anesthesia is necessary anterior to the mental foramen and when lingual soft tissue anesthesia is necessary. Contraindications: infection or acute inflammation in the area of injection, patients who are likely to bite their lip or tongue like physically challenged patients or children. Advantages of this technique includes a single needle penetration can provide wide area of anesthesia, which is again can be considered as a disadvantage when it comes to procedures involving a concised area or one or two teeth. Rate of inadequate anesthesia is high, which is 31% to 81%. Intraoral landmarks are not consistently reliable. The positive aspiration rate is the highest among all other nerve block techniques, which is 10 to 15%. Lingual and lower lip anesthesia may be causing discomfort to the patients and possibly dangerous, which can cause self-inflicted soft tissue trauma. Partial anesthesia is possible when there is anatomical variation like bifid inferior alveolar nerve and bifid mandibular canals. And when it comes to the lower anterior region, owing to cross innervation, there can be partial anesthesia. The alternatives for inferior alveolar nerve block includes Gauguet's mandibular nerve block, Vazirani-Akinosi mandibular nerve block, mental nerve block or incisive nerve block when the teeth involved is coming to that particular region, supraperiosteal injection, pedial injection or intraosseous injection. So, whenever we talk about any injection techniques, three main things are important. The landmarks for achieving the proper anesthesia. So, for this IANB, the various landmarks for this technique includes coronoid notch, mandibular occlusal plane and our mandibular foramen, and one soft tissue landmark, that is our pterygomandibular raphe. Second thing which we have to remember is the target area. As we know, what is a target? Target is something where something is need to be achieved. Say for example, in a bow and arrow competition, target is something where the arrow has to be passed. Similarly, here the target area represents the area where our local anesthetic solution has to be deposited. So, the target area for this inferior alveolar nerve block is the inferior alveolar nerve as it enters the mandibular foramen. So, here the medial part of the ramus where the mandibular foramen is located is our target area. Next point which we have to remember is area of insertion is the point where the needle is penetrated, and the target area is the point where the needle is stopped and the local anesthetic solution is ultimately injected. So, the area of insertion for this technique is the mucous membrane on the medial side of the mandibular ramus at the intersection of two lines, two imaginary lines. One is a horizontal line, another one is the vertical line. So, for this technique, a 25 gauge or 27 gauge long dental needle is preferred. So, in this picture, we can see the pterygomandibular raphe, which is a fibrous soft tissue which starts from the pterygoid plate and runs and joins the mandible near the external oblique ridge. Three parameters must be considered during administration of IANB: the height of injection, the anteroposterior placement of the needle, and the depth of penetration, which determines the location of inferior alveolar nerve. So, assuming the correct position for a right-handed administrator, sit at 8 o'clock position facing the patient, or if you are a left-handed administrator, sit at the 10 o'clock position facing the patient. Place the position in the supine or semi-supine if necessary. So, keeping the landmarks in mind, which are our coronoid notch, pterygomandibular raphe and mandibular occlusal plane in mind, locate the needle penetration site, which is the point of intersection of horizontal and imaginary vertical line. The horizontal line determines the height of injection and the vertical line determines the anteroposterior plane of injection. The height of injection lies about 6 to 8 millimeter above your mandibular occlusal plane, and the anteroposterior injection lies from the deepest point of coronoid notch to the deepest point of pterygomandibular raphe at approximately 3/4 distance. So, before giving any injection techniques, the tissue has to be prepared. Dry with the sterile gauze, apply topical antiseptic for 1 to 2 minutes. Followed by this, after locating the site of insertion of the needle, we have to place the barrel of the syringe in the corner of mouth in the contralateral side. Say for example, if I am about to administer local anesthesia for IANB in the right side of the patient. Now, I have to locate my landmark, which is the coronoid notch, using my non-dominant hand, which is my left thumb. After palpating the coronoid notch, I will be taking my needle and I will approach from the contralateral side of the patient, that is from the left side, preferably over the premolar or the corner of the mouth, with the syringe barrel placing parallel to the mandibular occlusal plane and having an imaginary bisecting line of my thumb finger. Without adjusting my thumb, I will start inserting my needle. So, as you can see, I am holding my left hand thumb in the coronoid notch and I am holding my syringe barrel parallel to the mandibular occlusal plane, and with the imaginary bisecting line of my thumb finger, I am starting to penetrate my needle, preferably the bevel of the needle facing towards the bone, but it is not critical for this particular procedure. So, once I start penetrating the soft tissue, I have to go straight without changing the angulation until I hit the bone. As you can see, as I proceed, the tip of the needle is approaching near our target area, which is the inferior alveolar nerve as or before it enters the mandibular foramen. The ideal penetration depth for adult patient would be 20 to 25 mm, which is 2/3 or 3/4 of a long needle. If the bone is contacted too soon, means we have approached too far anteriorly. In such cases, what we have to do is slightly withdraw the needle without completely removing it out from the mucosa, slightly reorient it posteriorly and redirect it towards the target area. If the bone is not contacted, means if we are going too far posteriorly, then again we have to readjust it by withdrawing it halfway, readjust it anteriorly and go and hit the bone. So, when we have reached our target area and we are reaching the bone, when the bone is getting contacted, we have to withdraw the needle approximately 0.5 to 1 millimeter to prevent subperiosteal injection. After withdrawing, then we have to do aspiration, which is essential for any injection technique. So, we have to aspirate in two planes, means, so after placing in the target area, I am aspirating in one plane and rotate it 90 degree and again aspirate in another plane in order to prevent any intravascular injection. So, if the aspiration is negative, we can proceed ahead by depositing about 1.5 ml of anesthetic solution over a time duration of 60 seconds. Now, slowly withdraw the syringe halfway, means this is the target area, we have achieved negative aspiration and we have deposited around 1.5 ml of local anesthetic solution. Then without changing the orientation of needle or angulation and without adjusting the needle syringe barrel orientation, withdraw it halfway without completely removing it out of the mucosa. Next, we are going to anesthetize our lingual nerve. So, the lingual nerve branch which runs near the lingual cortex near your mandibular third molar. So, this is the area of interest where we are going to achieve lingual nerve anesthesia. So, after withdrawing halfway, we will be aspirating again, and if it is negative, we will be depositing about 0.2 to 0.3 ml of solution for achieving lingual nerve anesthesia. So, after depositing, withdraw the needle and recap it carefully and wait for at least 3 to 5 minutes for the solution to act around the nerve bundle. Next, we have to evaluate subjective symptoms and objective signs. The subjective symptoms includes patient might report tingling sensation or anesthesia or swelling like feeling over part of the lower lip in the side where injection has been given, or tingling or numbness over the part of tongue where the injection has been given. Objectively, we can check the effectiveness of the anesthesia by using a electric pulse tester, and while doing the procedure, patient won't feel any pain during any invasiveness. So, after assessing the subjective symptoms and objective signs, the precautions which we have to bear in mind while administering this technique is, do not deposit a local anesthetic solution until the bone is contacted. The needle tip may be resting within the parotid gland near the facial nerve if when we are using long dental needle and the bone is not contacted anteriorly. So, if the facial nerve palsy is being observed, give assurance to the patient that it might get reversed back once the local anesthetic efficacy drops down. The possibility of failures of anesthesia is due to deposition of anesthetic too low below the mandibular foramen, or deposition of anesthetic solution too far anteriorly, laterally on the ramus, and when there is accessory innervation to the mandibular teeth. The possible complications which can arise are hematoma, which is very rare, and if it arises, we have to apply pressure and cold pack in the area for minimum of 3 to 5 minutes. Trismus or muscle soreness which can lead to limited movement and transient facial paralysis. So, when inferior alveolar nerve block is used for any procedures involving mandibular molars, then it might be needing to be accompanied by another technique, which is our long buccal nerve. So, let us discuss about long buccal nerve block, which is commonly referred to as buccal nerve block. The success rate is approaching to 100% because it has very fewer other important vital structures nearby it. It is readily accessible to the local anesthetic solution as it lies immediately beneath the mucous membrane and not buried within the bone. The nerves anesthetized is the long buccal nerve, which is the branch of anterior division of our mandibular nerve. In this slide, we can see the long buccal nerve as it travels in the buccal aspect of our mandibular molars. So, areas anesthetized after achieving long buccal nerve block is the soft tissues and the buccal mucoperiosteum lying buccal to our mandibular first, second and third molars. So, the indication for long buccal nerve block is when the buccal soft tissue anesthesia is necessary for any dental procedure involving mandibular molar region. As for any other injection technique, the contraindication lies when there is any infection or acute inflammation at the site of injection. The high success rate and technical easiness is considered as advantage, and the potential for pain if the needle contacts the periosteum during injection is a disadvantage. The possibility of positive aspiration is very minimal or negligible. Patient rarely experiences any subjective symptoms owing to the small size of areas getting anesthetized, and objectively patient will not feel any pain when the area is instrumented. The safety feature is needle contacts the bone, therein preventing over insertion. So, the landmarks for this is the mandibular molars, mucobuccal fold, and the area of insertion for this technique is the mucosa adjacent to the most distal mandibular molar. So, in this slide we can see the needle being inserted in the buccal aspect of the mandibular molar. So, this is the external oblique ridge region where the long buccal nerve branches out and comes here. So, the area where we are going to give long buccal nerve block is buccal and distal to the most posterior teeth of mandible, that is our mandibular second or third molar. So, the needle parallel to the mandibular occlusal plane, we have to go and hit the external oblique ridge here, aspirate and deposit approximately 0.2 to 0.3 ml of local anesthetic solution. Complication is very few and very rare. Might develop hematoma which can be bluish discoloration and tissue swelling at the site of injection. Blood may exit the needle puncture point into the buccal vestibule, and if it occurs, apply pressure locally for 3 to 5 minutes. So, we are arriving to the end of the session. I hope this was informative, and please bear in mind these local anesthesia techniques are essential for practicing dentistry throughout our practice. If you have any questions, please feel free to contact me. Thank you.